Right, well, we'll commence this session, the plenary session for the Lowenthal and the Pioneer Lectures. My co-host is Ros Francis, the incoming president of the ANZSNM. My name's Dale Bailey and I'm the outgoing president of the ANZSNM. It's a great privilege and pleasure to welcome two colleagues and good friends to give these lectures today. Both have been trailblazers in their own fields. The first lecture will be by Professor Carl Munoz-Ferrada. I suspect many of you don't know Carl because he just works away at innovation and creating new things in his company in Sydney and gets on and does the job. He has his first degree, Bachelor of Science from the University of New South Wales, and then took a PhD in the University of Lund in Sweden. He currently holds honorary professorships in both the faculties of medicine and engineering and science at the University of Wollongong in New South Wales. He is the principal and the owner and the main driver and inventor behind a company called Gamasonics. Gamasonics have a range of activities from calibration and shielding and the rest of it, but the more interesting stuff that Carl does relates to solving problems related to radiation. Many decades ago now, he started a collaboration with Roger Uren and Rob Herman-Giles in Sydney to develop sentinel lymph node probes to improve outcomes in breast cancer patients. And to this day, he is still travelling the world teaching people, especially in emerging countries, how to use these probes. So I'd like to welcome him to the stage now. While he's coming up, we'll get his title slide up. So the title for Carl's talk is The Gamma Probe, 25 Years and Beyond. And it's a great pleasure to welcome you to give this talk to the ANZSNM, Carl. Thank you.
Thank you, Dao. Well, as Dao has said, I spend most of my time developing new gadgets. And one of the few that I have taken part in my life was the Gamma Probe. That's going back 25 years ago. And probably a little bit more. During that time, there was nothing reliable to, sorry to ask you, but is this catch you move forward here? I'm trying to. Which one is it? Okay. Thank you. As you can see, the Gamma Probe was developed sometime in '94, and the first clinical unit was actually in '98. 12 hospitals participated in the clinical trial. So there was an operation, not just mine, but there was a few, and the students, the hospitals, the university, and it was possibly one of the largest projects that we have undertaken at that time. The encouragement came from the surgeons, mainly. There was nothing available that we can say suitable to do the sentinel nodes at that time. So our job was to develop something that will give you a direct direction in surgery as how to find a node. I say, okay, I'm going to give you a bit of the physics that was involved in that. We needed to find a node, so we needed to use a number of sources related to TC99 with a 140 energy. And we created several jigs and phantoms where we can move the probe in different directions. And we had it at different thickness. The activity was constant, and we moved the probe detection in different directions. That was basically the most busy part of the experiment through a year and a half to be able to deliver something very reliable. Making detectors is one thing, but trying to make a probe that you need to work in surgery is another one. So I'm just going to give you a short film clip from the ABC see if I can get it to work.
Coming up on Quantum, the stellar search for signs of the next ice age, a new tool to track down rogue cancer cells,
This woman, we'll call her Anne, has just been diagnosed with breast cancer. She's facing surgery to remove the tumour and a large section of breast tissue. Until recently, surgeons would then remove most of the lymph nodes from under Anne's arm, just to be certain no cancer remained. This lymph surgery can itself result in permanent physical disability long after the operation.
People get restriction of shoulder movement, numbness in the inside of their arm, lymphedema, swollen arms, which can come on any time up to 5 or 10 years after surgery.
Now, instead of removing 10 or 20 lymph nodes just in case, a new technique is helping surgeons detect the single lymph node most likely to be affected by the cancer, the so-called sentinel node. The lymph system is the body's garbage disposal service, carrying invaders such as bacteria to the lymph nodes where immune cells destroy them. But diseases like breast cancer can spread by hitching a ride in the lymph fluid. The immune cells in the lymph nodes can't recognise stray cancer cells. The cancer is free to progress from one node to the next. In breast cancer, it's essential that affected lymph nodes are removed to stop the cancer spreading even further. To detect suspect nodes, Professor Roger Uren and his colleagues developed a technique called lymphoscintigraphy.
The node in the axilla.
They inject a radioactive solution which enables them to see the lymph channels draining away from Anne's tumour. This shows up the sentinel node, the node most likely to contain cancer cells.
What you see here, this is the injection site, and you can see a little line passing up to this black spot here. That is a sentinel node in the right armpit. So we end up seeing the actual lymph vessels that leave the area, and we follow those vessels to the first lymph node that they meet.
Images like these provide a rough guide, but actually finding the sentinel node during surgery, among dozens in Anne's armpit, is a far more difficult task. To help solve this problem, Dr. Carl Munoz Ferrada from the Gamma Sonics Institute in Sydney developed a miniaturised version of Professor Uren's machine. It's called a gamma probe. Professor David Gillette, one of Australia's top breast cancer surgeons, was the first to try out the gamma probe.
Just putting a sterile glove over the probe. I'm just using the counter now to double check where that tumour is.
Anne's cancerous breast lump is relatively easy to remove, but the sentinel node is more difficult to find.
We can see here in this upper part of the wound is where the higher counts are.
The gamma probe hones in on the radioactive solution injected earlier. It should be concentrated in the sentinel node.
If we shift it by half a centimetre, we lose that radioactive count. It's right in this spot here.
The node is now safely removed, but without the gamma probe, it may not have been found.
So we can give that to the pathologist and she can tell us if there is any tumour in that gland.
The pathologist gives Anne the all clear. The operation is completed without unnecessarily removing any healthy tissue.
This lady's prognosis for that breast cancer is excellent. I can't imagine that we would operate on patients with breast cancer these days without the gamma probe and without using sentinel node technology.
So the beginning, as you can see, the surgeons are very excited that they had a tool now that can actually use in surgery and be able to find a sentinel node. So the project continue, and I'm not going to go through all the dissertation of the different part of the history of the lymphoscintigraphy, because I think we saw that in the film, and I got a lot of slides to go through. But I had that in mind to pass it to your hands. Here we have a lymphoscintigram, sorry, an injection of the isotope to be able to see the channels with the blue dye, which is normally used in surgery. But as soon as that blue dye tends to penetrate the deeper channels of the lymphatics, we cannot see the lymph again. And well, going back to in those days, they did the trial. We have Morton, Cavagna, who initiated this going back to the 70s, and then Morton, who brought it into the known to the rest of the medical community, Uran in Sydney, and Giuliano in Italy. They have basically a big part to play. Sentinel node, as you can see for the dissection here, it's a node which has got several channels that for access and entering of the actual lymphatics and the isotope. And then we have the different type of colloids. Colloids is basically a very important part of the actual injection because it's going to give the size of the isotope, the size of the movement of the isotope through the lymph, because if it's too small, it's going to move too quick. We're going to see it in nuclear medicine, but we're not going to see it in surgery. And if it's too big, again, we are not going to be able to see it at all. So for that reason, choosing the right colloid is very important. The activities that we see optimal to the usage of the probe, again, we needed to study that. And that took us quite a long time to get to a definition, what part, what activities better to be used. Here we got 10 MBQs to 5 MBQs, possibly the optimal, without having too much activity in front of the surgeon for an hour, because again, the project was not only developing the device, not only the injection, but we needed to maintain radiation protection for the rest of the staff, which are not considered members of the radioactive community. Surgeons, nurses are not familiar with radioactivity. So we created two injections, one for 40 MBQ and one for 20 MBQ, and as you can see, the different times are to be obeyed if it's either melanoma or breast cancer. Again, in the body we have two lymphatic systems, and it's very clearly seen during surgery. We have the external lymphatics and the internal lymphatic system. And this is basically the excitation of a lymph node, lymphatic channel, how to penetrate the rest of the channels. Lymphatics, again, we have sulfur colloid, sulfur albumina, we have antimony, and for many years Australia did use antimony. But recently I noticed that they're moving more into sulfur colloid. The injection, again, optimal injection was also needed to be defined, and we got the peritumoral injection, the subtumoral and the anteperitumoral injection. The technique is very simple. When it's done properly, you inject in 4 different positions in the upper quadrant, lower quadrant of the breast, and then you wait for a few minutes to see if the isotope is moving to the nodes. And after that, you come with a gamma probe and you try to identify which nodes are contaminated with the isotope. Again, definitions needed to be fine and the best injections that we needed to be done. Nuclear medicine will do that, but in surgery there's a different behavior of the isotope in regard to the incision, because blood and isotope tend to contaminate the actual procedure. Here we have a problem that I encountered with the surgeon. The surgeon don't appear to have a lot of knowledge on the images supplied by nuclear medicine, and they tend to disregard, in many cases, the actual lymphoscintogram. And it's purely because the bridge that is needed, which I did become for several years between nuclear medicine and surgery, the interpretation of the lymphoscintogram. As you can see here, we have the actual injection, and then we have notes. It's very easy for nuclear medicine people to understand that, but for a surgeon, that is very complicated. I mean, here we have a contrast by putting a source, but what we tend to do in some other parts is by doing a quick drawing, and the surgeon feels much confident by looking at it this way. And here, for argument's sake, you have a frontal, and then you got a lateral, and again, shows a node hiding on the lateral image. Here we have 3 channels of the lymphatics, which we identify with the gamma probe, and we have a node under the axilla. Here again, we have an incision, sorry, we have the injection and the melanoma side, and then we have 2 nodes which I have spread in different directions. You can see some of that, but in surgery it's very difficult to find that. Again, we're going back to the injection side. For Roger Durant at Mason Center in Sydney, we developed a gamma probe with an earphones, so he can actually hear the sound of the gamma probe when he's marking the patient, making it much easier and less disturbing for the patient. In our research, as you can see, it's not just developing the probe. We need to see the timing that the lymphatic is taking the isotope with the colloid. So Roger's here has got the injection, and I got the probe, and between the two, we're trying to identify the time and the activity that is being injected. We got 29,000 counts at the size of the injection, and at the size of the node, within 45 minutes, we got 22,600, which is basically 10% of the activity tend to move to the node. That gave us an efficiency result on the detector, and at the same time to see the linearity of how the unit is behaving. Here at Concurrent Hospital, we did also some experiment of lymphatics moving from the tumor to the node, and it's an area there which is marked in red that it caught my attention. So after we did the surgery procedure, we took that piece of the patient and we put it under the gamma camera again, and we found that those dots you can see there is metastasis and transition. So things like that, not many people prepare for. Collimators, again, the gamma cameras, no matter how new all they are, they all have a purpose. But to have a gamma camera, to have the best imaging for sentinel node, we needed to create and develop a collimator. So we use nuclear fields in Sydney to make the collimator. The first one at the top is the collimator that the normal manufacturer supply, and the bottom one is a collimator that we finished manufacturing or designing for sentinel node. Again, here we got the optimal time and the activity that we need to find the higher number of possibilities with nodes. Again, here, time versus activity was very important to follow. That's a rule of physics. The research which was created to understand the behavior, I received more than 500 reports from surgeons around the world, which gave us a better understanding of the directionality. So the probe was made probably 10 different times or more to try to get the optimal performance. So it's not just making a detector, it's all the extras, they're hiding there. So it took us 4 years to come up with the final detector. And here, David, Gillette, and myself, we are trying to mark the node of the patient before we go into surgery. So again, we took the probe from injection time to surgery and then to pathology. Here we have encountered the position where we think the node is precisely there. And well, going back to the reason of doing this is to save the population, the female population, of the difficult times of having breast cancer, and we're losing that to 70% in those days. Today, we're only losing 30% compared to 70% it used to be 25 years ago. The probe now have moved into gynae work, and we are looking into prostate. So we have, we still got a lot of work ahead in our hands. We had done at the RDI hospitals and surgery as well with the surgeons there to identify melanoma. And again, it's a different type of procedure because nodes and tissue absorbing the isotope, and the colloid is a different area. This is some of the research forms that we did in those days, and trying to identify what type is the best patient, the age. We found also the patient doing a lot of exercise, like push biking and whatever. When they have an accident, they tend to have more problems. The other patients, that they haven't had that because they damage the lymphatic tracts. And due to that, it's more difficult to proceed with the surgery of the nodes. And then after the probe was finished, my job was around the world, basically to train surgeons to understand not only the usage of a probe, but also to understand what they're looking for. And here, I'm doing a demonstration where one of the procedures that was done by the IEA overseas, showing the surgeons the difference between an axillary dissection and a simple biopsy of a node, which is quite different, to lose half a kilogram of flesh to losing only a few grams, and without the complication that the procedure of axillary dissection is going to bring into a patient 10 years later by acquired lymphedema, enlargement of the area, and pain for the rest of their life. So, 25 later, we have developed a new detector, which is far faster than the early one. It's wireless. And we found that, I don't know if we can go any further with that type, so this unit can do anything. And here, recently, I was just, again, in Nepal doing some surgical procedure, demonstrating this by the IEA. And again, the more you do, the better results you're going to get. And okay, selecting the patient is the age, the damage to the lymphatic, which I mentioned briefly a few seconds ago. If you had a biopsy, they're going to have problems. If the node is too small, the time of the injection, the time of surgery, room temperature, patient blood pressure, and isotope activity and colloid. The time of the injection and surgery is very important again, because with some of the colloids, in surgery, you can't find the node. Even so, the node was still there. We can't see it, simply because the colloid was too small, so the isotope just went through the node and disappeared. So there are the different problems, and we found that 20 and 40 MBQ are very constant type of injections that can be used for the procedure and given very good results. Those that they did benefit from the project in the past, the students from Wollongong universities and other universities across the world. So we have one from Hong Kong there, one from Australia. And we have many more since then. But some of them today, they're going to take key positions in hospitals around the world with a new understanding of sentinel node. Because Dow suggested that I should put other R&D that we did, so I have pushed the talk a little bit, but I don't know if they're going to come up, but okay, we did receive recognition, but when Japan had the problem with the Fukushima reactor, again, we were contacted by Japan to find a solution, not only to find the radiation, which was falling over Japan, but also what they're going to eat, because everything was contaminated. So we developed what is called the Fukushima, and we needed to do it with a very short time. You can see there is no time to waste. So within 3 months, we developed a radioactive detector, which had to be made of plastic, because the problem was chloride 36. Chloride 36 is very acid product. It's got a half-life of 360,000 years or something like that, with plus or minus 4,000 years. So we had no time, and in 3 months we needed to develop the detectors. Here the Japanese inspectors, they cannot show the face and they cannot show you where they're doing this, because they don't want members of the public to know where it's radioactive. Go to the background there, 300,000 years, plus or minus 4,000 years. And as you can see, the chloride 36 start moving across the world, and that's what actually was happening during that time. So in 2011, we had a lot of problems that the world wasn't telling to the public. We participated by developing all this equipment for them. Not only that, this is what a Japanese actually made out of Fukushima detector with 3 pairs of socks, as you can see that, good radiation protection. And then producing the units in Sydney and ship it to Japan. Then the problem of food contaminated. So we needed to develop a radiation detector that can pick up radioactivity at a level of salt that we consume in Australia. And salt in Australia does have a small amount of radioactivity. So we use that as a source to calibrate the detectors. And these units, they were installed everywhere in Japan, wherever the Ministry of Health was actually inspecting food arriving from the country. Then the 30 porter. The 30 porter was actually born in 30 years ago. The first unit was done for Gordon Chang. And I did that by spending 2 days with Gordon, measuring where was he receiving doses and the technologies receiving doses on those days. And the first 30 porter that I did for him was actually this one that you see in the picture. And today, this is the 30 porter, which was designed for PET and MRI facilities because it's totally non-magnetic and can be incorporated with an infusion pump or can be with a syringe, single syringe. So this is part of the R&D that we've done in the last, we can say, 3 years. Or we have many more, but this is more related to nuclear medicine these days. Then we have also done the iodine 131 patient monitor. So when you discharge the patient, you don't need to do measurements with a servometer. It's done automatically controlled by the nurse escorter or by the physicist, where you can see the dose of the patient declined continuously during the 4 days that the patient is in the ward. I think that it's got a great future because we also can use it in brachytherapy and radiotherapy. And in nuclear medicine, it should cut down the inconvenience that you don't know when and how to discharge the patient. Then one of the largest projects again is the EnviroRad, which is new, is to protect the environment mainly from radioactivity, but not only that, the contamination which is created by the retention tanks they are actually in the majority of the hospitals across the world and Australia, where radiation at the end doesn't really have much of importance. It's more the cocktail, the little cocktail of bacteria, heavy metals, chemotherapy, and radiation, which is incubated for 90 days before it's discharged to the environment. In this case, only what we're doing is injecting air, oxygen, 20%, and dilution, and the product is basically moved from tank to tank to be discharged with days, not with months. This is the design of the unit today. The largest hospitals across Australia and overseas, especially in the Middle East in these days, are taking advantage of this. There is the largest system in Australia is in Fiona Stanley Hospital in Western Australia and Liverpool Hospital in Sydney, although we got St. Vincent Hospital and a few other ones in New South Wales. So basically, this is my talk. I have pushed things through because I don't want to spend too much time with you guys putting up with me. So I think we'll finish up here, and I thank you for listening.
Thank you very much, Carl. I'll just read to you from the remit of the Lowenthal lecture. It's a 45-minute presentation in a plenary session of the ANZSNM annual meeting. The subject of the lecture is to be in keeping with the theme, the role of physical and biochemical measurements in nuclear medicine. I think, Carl, you've admirably demonstrated that you have met those criteria well.
Thank you.
We congratulate you on all your work. I want to also add that Gamasonics is a sponsor of an annual award here at the meeting in the area of radiation measurement and detection and safety. So we thank Gamasonics for that as well. Are there any questions for Carl? Yes.
Can you hear me?
Yes.
Thank you so much. That was a really good long-term perspective about sentinel node biopsy. So just as a background, I'm a fellow at the Peter Mac Hospital across the road, and I do a lot of sentinel node lymphoscintigraphy for melanoma. I'm just interested to know, a lot of my cases, I sort of, after doing a beautiful imaging and, with SPECT CT, finding a draining node, I sort of sit there and wonder why we're doing it, especially with intermediate grade, intermediate thickness melanoma, when PET is very useful for staging. Where does that sort of fit in? And are we still doing a good job in still doing sentinel node lymphoscintigraphy for these patients, who will then go on for having a biopsy, when we know that completion node dissection doesn't improve survival? Are we better off staging these patients with PET and avoiding doing a lymphoscintigraphy?
Well, doing it with PET, the only problem is the surgeon's not going to have the opportunity to find the node next day or a few hours later because the isotope moved too quickly. So for that reason, I think it might be good for the imaging aspect, but I don't think it would be very good in surgery because the complicated part is actually surgery. When blood comes into place, you can't see anything.
Yeah, but it doesn't, so the completion node dissection doesn't improve survival. And that was at the NEJM data last year. So, we are identifying a node positive for melanoma, but that's still used as a staging mechanism. And I'm talking about the PET used for a systemic staging point of view for an intermediate, melanoma that's higher risk for metastases anyway. So, you know, we're doing the biopsy and we're finding the perfect node, which I totally agree with, you know, with breast, but with melanoma, it won't change. From what I'm seeing, I just don't understand, and I could be totally wrong, I'm still very junior, but I don't understand where we're sort of fitting in terms of staging point of view.
Well, with melanoma, are you referring to the nuclear medicine part or the surgical part?
No, the nuclear medicine part, so the lymphoscintigraphy.
Well, lymphoscintogram will give the surgeon an indication there is 1 or 2 complicated nodes. But in surgery, becomes a different situation because blood is going to confuse the surgeon and it's not going to allow him to see anything. So when you're saying biopsy, the biopsy they are doing is basically a lymphobiopsy and not just a biopsy of the node.
Yeah, but that's used as staging, isn't it? Isn't that helping them for staging purposes?
No, normally they remove the tumor at the same time.
Yeah.
So the patient is closed and sent home or goes under radiotherapy, depending the prognosis from the surgeon or the endocrinologist. Mm. So there is no further biopsy in between. What I was referring before is a biopsy way before the patient goes under the gamma camera. And that biopsy tends to produce problem to nuclear medicine.
Absolutely, exactly. And that was before, you know, PET data came through.
Yeah.
And so with these high risk melanomas, these intermediate thickness melanomas, when we know there's a high risk of metastatic disease anyway, and with immunotherapy playing a strong role, you know, those taking that one node out may not have as much importance, you know.
Well, the rule of thumb in surgery is if you go more than 3 nodes, they do axillary dissection or in the area of the body that is required. Exactly. But if it's only 1, they tend to consider safe to be left in that way. What I found is the phantom node, which I don't know if I didn't bring that into the context because I didn't want to. Normally, I talk to the surgeons about that. When we look at the lymphoscintogram, we tend to see the channel, as Roger Uren was showing there, and then the channel disappears. And then further on, we see another little node lighting up. What I see here is, and I have got that in surgery to remove that little piece. And we found normally that there is a node which didn't become contaminated with the isotope because it's already blocked. And that node is actually your sentinel node in that case. So sometimes we say that because nuclear medicine have allowed that node to become contaminated with the isotope is a sentinel node. If there is a node and there is a channel, there's a possibility there is a node hiding that we don't see.
Right. Okay. Thank you so much. Yep.
Carl, what I like about a lot of the work is that it's obviously very multidisciplinary.
Yeah.
What's been the most fun part of it?
Well, to me, it's been exciting, and it's always exciting to have that because, I mean, what you make, you want to see it work, you know, and it's very rewarding when you have designed something. Of course, I got a complexity of engineers and different people supporting me. I mean, and the idea man, we can say, and who had to get the project put together. But there is other people there who also deserve to be brought into the context. I got engineers, software engineers, I got biomedical engineers, I got biochemical engineers, I got designers, inclusive dentists playing roles with that. We are lucky that we've been tied up for years with a medical center that we've been running 18 medical centers, and we got data from there as well. But now, as a question, yes, it's very fulfilling to be able to develop something and see it to work and be able to see a patient walking and then the family come and thank you for what you did. That is, give you a kick. Thank you.
Thank you so much for that.
Okay, thanks.
Thanks.
So I'd now like to welcome Professor Turner to the stage for his pioneer lecture. Professor Turner is a senior clinical academic consultant physician and nuclear medical oncologist at the University of Western Australia. He founded the Department of Nuclear Medicine at Fremantle Hospital in 1976 and practiced as a consultant physician in general medicine and director of nuclear medicine until the transfer of the department to Fiona Stanley Hospital in 2015. Professor Turner performed the first phase 1 and 2 trials of samarium in palliation of skeletal metastases in the late 1980s, and since then has published nearly 100 innovative clinical studies in the international literature. His encouraging results in neuroendocrine tumours treated with lutetium octreottate plus chemotherapy led to the ControlNet study, which is now in place across Australia. Professor Turner founded the World Pharmaceutical Therapy Council of the World Federation of Nuclear Medicine and Biology and is a past president of the World Association of Radiopharmaceutical and Molecular Therapy, WARMTH. He serves on the editorial boards of the World Journal of Nuclear Medicine, Annals of Nuclear Medicine and Cancer Biotherapy and Radiopharmaceuticals, and has written a book on the natural history of cancer. We very much congratulate Professor Turner on being awarded the Pioneer Lectureship of ANZSNM at the World Congress here, and his talk is titled Global Harmonisation of Clinical Practice and of Theranostic Nuclear Oncology. Thank you, Professor Turner.
Thanks very much. And thank you very much for the invitation to give this Pioneer Lecture. It's an honour and a privilege to be with you today. Giving a Pioneer Lecture, the main qualification seems to be growing old, but
big green button.
In the World Federation meeting in Sydney in 1994 is where it all began, and Provan Murray was the president at that time, and he allowed me to organise the first international colloquium in radiopharmaceutical therapy. And you may recognise some of these younger faces. And this was held every 2 years, and in the second year in Kyoto, we decided to have a formal organisation with the World Federation of Nuclear Medicine and Biology and form a World Radiopharmaceutical Therapy Council. And the role of that council was to promote therapeutic nuclear oncology and make it available, affordable, practical, safe and effective throughout the world. And that metamorphosed in 2008 into WARMTH, with now collaborations with all the major nuclear medicine organisations, and the mission is to promote and harmonise safe, effective practice of therapeutic nuclear medicine throughout the world, and to encourage research and translation of novel radiopharmaceuticals into standard oncology treatment protocols. Those who cannot remember the past are condemned to repeat it. And the history of nuclear medicine provides enlightenment for the future of theranostic nuclear oncology. In the beginning, there was radioiodine therapy of thyroid cancer. First patient treated in 1945. And this is the birth of nuclear medicine. And it's generally acknowledged as the advent of theranostic paradigm. Just 2 weeks ago, I wrote a review article which was published in the British Journal of Radiology on recent advances in theranostics and challenges for the future. And that looks at only those advances published or presented within the last 15 months up until mid-February this year. So some of those are being incorporated into this lecture, but what I want to do first is to look at radionuclide therapy with radioiodine of thyroid cancer. And I don't want to look at it as a nuclear physician, I want to look at it as an oncologist. There has been in 75 years no systematic determination or documentation of efficacy and toxicity. There has been no formal phase 1 dose finding study. There is no defined maximal tolerated dose. And bearing in mind that what we loosely call dose, as is administered activity measured in gigabecquerels, it does not equate with radiation absorbed dose in grey. There has been, in 3/4 of a century, no formal prospective randomised control trial to define objective response rate, progression-free survival, or overall survival. There is no objective validated evidence base. That's a pretty damning indictment on our theranostic nuclear medicine practice. Let's talk about dose. The European Council Directive of 2013 has just come into force across the European Union, February this year, and it states that for all medical exposure of patients for radiotherapeutic purposes, exposures of target volumes shall be individually planned and delivery appropriately verified. The emphasis is on justification and optimisation. If we look at I131 dosimetry versus an empiric activity in metastatic differentiated thyroid cancer, we can look at the comparison between Memorial Sloan Kettering, where they routinely do whole body and blood clearance dosimetry, and Gustave Roussy in France, where they just give an empiric activity of 3.7 gigabecquerels. Now, in New York, they varied the administered activity between 2.7 and 18.6 gigabecquerels on dosimetric criteria. There was no statistical difference in overall 5-year survival, and no toxicity data was given. The absence of evidence is not evidence of an absence. And this trial was editorialised in the Journal of Nuclear Medicine last year. Routine use of whole body and blood clearance dosimetry without lesional dosimetry provided no overall survival advantage when compared with empiric fixed radioactive iodine activity in the management of thyroid cancer patients with radioiodine and distant metastases. However, this argument requires an excellent prospective non-inferiority randomised study evaluating typically the one parameter of interest and controlling all other confounding factors. This is mother's milk to oncologists. The study of D'Andreas is not such a study. Let's consider no-dose radioiodine. Now, it's acknowledged that adjuvant I131 therapy improves progression-free survival and overall survival in advanced stage, well-differentiated thyroid cancer, but there is little or no reported benefit in low-risk or intermediate-risk thyroid cancer, where the progression-free survival at 5 years is greater than 97% without radioiodine. If you look at a comparison of low administered activity with higher administered activity in a study published in 2013, objective response rate was the same, the metastases were the same, retreatment was not statistically different, the complete remission rate was 3/4 in both, the death rate was the same at just over 2%. Again, no toxicity data. And the conclusion was non-inferiority of low activity. So less is more. Or is it? Same editorialist the rates of recurrence, persistent disease and death in the so-called non-inferiority study of Castagna et al. Are less than satisfactory. And on the presented data, one could conclude that neither less than 1.8 gigabecquerels nor greater than 3.7 gigabecquerels of I131 is tumoricidal, and that both dose levels are equally ineffective. Less is more. Let's do a reductio ad absurdum. If 1.8 gigabecquerels of I131 were to be compared with no treatment with I131, and the outcomes are demonstrated to be the same, would one conclude, one, that they are equally effective, two, that 1.8 gigabecquerels I131 is not effective at all, three, both are correct. Instead of these interminable trials that don't answer any questions, perhaps the future orientation for thyroid cancer is to enhance the tumour cell uptake by various other mechanisms to prolong tumour cell residence time of the radionuclide, to minimise salivary gland toxicity, to refine the lesion dose as opposed to the whole body and organ dosimetry. But what I want to concentrate on is to monitor and define myelotoxicity. We don't seem to worry about myelotoxicity too much with I131 therapy. But analysis of nearly 150,000 thyroid cancer patients, well-differentiated thyroid cancer patients of low, intermediate and high risk, in the SEER registries were analysed. Half of them had received radioiodine adjuvant therapy. And the hazard ratio for acute myeloid leukemia was 1.79, which is not insignificant. And the median overall survival of those patients who developed radionuclide-induced leukemia was 8 years, as opposed to 31 years in controls who hadn't received I131 therapy. And worse, the treatment-induced leukemia had a worse prognosis than AML, which arose de novo. So there is a myelotoxicity risk. 2009, I was invited to review in Current Pharmaceutical Design the definition of pharmacokinetics for individual patient dosimetry. That's in routine radiopeptide and radioimmunotherapy of cancer. And I came to the conclusion that you had to measure, preferably prospectively, the radiation absorbed dose in grey in order to be safe and effective. And we should define the dose in grey to the critical normal organs. And that's precisely what we did when we used samarium-153 dosimetry in EDTMP. The administered activity was a tracer amount of 750 megabecquerels, and we did decay-corrected whole-body scans at 10 minutes and 4 hours, and then topped up their therapy dose according to our calculation of a radiation-absorbed dose to the red marrow of 2 grey. So 15 minutes and 4 hours, very simple to do, and by 4 hours, all the activity that's not going to be in the tumour has been excreted by the kidney. So with that dosimetry, we avoided myelotoxicity, and we had an objective response rate with pain control of 83%. Incidentally, the in-house kit cost was $150. And I'll come back to the question of financial toxicity of our treatments later. Non-Hodgkin lymphoma, the indolent non-Hodgkin lymphoma, can be treated very effectively with radioimmunotherapy, and we were using I131 rituximab for those indications. In the initial studies with I131 tositumumab, Bexar, they did dosimetry studies, and it was interesting to look with Zevalin, where they don't do dosimetry because it's a pure beta emitter with Zevalin. The objective response rates in the clinical trials with very selected populations could not be emulated in subsequent routine practice. And the CR rate was also much lower than those expectations. And the toxicity was also greater in the non-trial treated population. With I-131 rituximab, we didn't find that, and simply because we started treating real-world patients without heavily selecting them. So we took our ordinary patient population and we found that there was no difference in the toxicity and no difference in the results. And the objective response rate was 3/4 of the patients, and half of the patients achieved a complete remission. That's in relapsed indolent non-Hodgkin lymphoma. And the reason for that is we did tracer dosimetry. 185 megabecquerels of I-131 rituximab were given. Scans were performed over a week, whole body scans, and then we were able to look at the retention of the radioactivity in that individual patient. And as Richard Vahl said in the session this morning, if you treat by body surface area or by weight, then a quarter of the patients will be under or over treated by greater than 10%, and some catastrophically as far as myelotoxicity goes. So that was our experience in, that's about 200 patients. And that's illustrated in these three curves from different patients. The top curve shows a patient where the retention is high and the therapy activity was 1.3 gigabecquerels. The patient in red is the more normal clearance, and that was 2.5 gigabecquerels. And the patient who cleared the I-131 rituximab very quickly received 6.4 gigabecquerels for the same radiation absorbed dose to the whole body, which is 0.75 gray, and hence less than 2 gray to the red marrow. We started treating our patients first line with follicular lymphoma. Those patients satisfied all the criteria that haematologists have for treating those patients, so they would have received R-CHOP or other conventional therapy. Now, we've had an 8-year follow-up, and we've actually followed these patients for 10 years. Because in Western Australia patients can't go anywhere, none were lost to follow-up. They were all given the prescribed whole body dose of 0.75 gray. There was no hospital admission of any patient required at any time, because they're all treated as outpatients. There was no episode of bleeding or sepsis. The minimal thrombocytopenia or neutropenia was self-limited. And there has been no myelodysplasia or acute leukemia in a median follow-up now of 80 months. No financial toxicity. The response is on Deauville criteria at FDG PET scan at 3 months. The objective response rate in our population was 98%. Time to next treatment, the median exceeds 97 months. It hasn't been reached. And these are the sort of patients we were treating. That you can see that there's a high tumour burden, the spleen is huge, all the lymph node stations are involved. 3 months, complete remission. 30 months, complete remission. This patient is still in complete remission at 12 years. And that's not an isolated instance. So if you achieve a CR on Deauville criteria, then you will have a very prolonged response in this non-chemotherapy treatment. And now we're able to look at the follow-up of R-CHOP, which is the conventional therapy, over 8 or 10 years, and the progression-free survival is 40 to 50%. And there's an incidence of myelodysplasia and acute leukemia. If you look at the initial study, we've got a 77% progression-free survival and no MDS or AL. And we've actually looked at our results for combining radioimmunotherapy with 3 courses of RCHOP, which have not produced a complete response. And those are even more impressive with a progression-free survival at 5 years at 92%. All our patients are treated as outpatients, and I know throughout Europe you can't do that. And we published in the Journal of Clinical Nuclear Medicine to put all the data out there that it is safe. And they do achieve release criteria which are international standards. We also looked at the management of fear of radiation exposure in carers, because this was around the time of Fukushima and the Japanese were talking about radiophobia. Radiophobia does not exist. To be afraid of radiation exposure is not irrational. A phobia is irrational. So if you accept that it's rational to be worried about radiation exposure, you can deal with it on a rational basis. And we published this in the Japanese literature, and the middle author is a professor of psychology at the University of Western Australia, and his specialty is arachnophobia. So I think that if you hear about radiophobia, you should refute that. We can extrapolate to lutetium-177 rituximab the same sort of dosimetry principles as I-131 rituximab, and it has a better radiation profile, and this is the sort of retention graphs that we anticipate, and we will be starting the ALLURE study later on this year as a prospective first-line outpatient radioimmunotherapy. If we look at lutetium peptide receptor radionuclide therapy, the radiation exposures are the same, so that all our patients are treated as outpatients, and we can measure the amount of activity, and they all achieve the release exposure rate at 1 metre of 25 microsieverts per hour, which is the international standard. No one believed us. 15 years of routine practice with single and multi-centre studies in nuclear medicine of the efficacy of radiopeptide treatment in neuroendocrine tumours. The oncologists wouldn't believe us. The European Neuroendocrine Tumour Society would not incorporate radiopeptide therapy into their guidelines except as a last gasp treatment. But the NETA study, which wasn't that, didn't show the results which were as good as we'd been achieving, nevertheless convinced the oncologists it now has level 1B evidence, and the oncologists accept that. But if you look at their study, it did show an advantage over controls with a partial response rate of 17%, but the progressive disease rate was 23%, and the PFS was estimated to be greater, but it hasn't been reached. If we compare it with the same profile patients treated over a 10-year period in Rotterdam, these were all Dutch patients because they were followed up very carefully, not the fly-in, fly-out patients, there's 94 of them. The partial response rate was 30%, and the progression-free survival 2 years. But if you combine that radiopeptide therapy with capecitabine temozolomide, which is what we did, and this is in comparable patients, you can increase the CR rate. You start getting a complete response rate, 13%, and the progression-free survival goes out to 31 months. The response is even better when you do chemotherapeutic radiosensitization of PRRT in pancreatic neuroendocrine tumours. And this is a comparison with comparable patients on the Dutch protocol, and they got a progression-free survival of 31 months, but there was 15% progressive disease. If you add chemotherapy, there's no progressive disease. The complete remission rate was 13%, PR rate of 67%, and the progression-free survival now out to 4 years. And this is the waterfall plot showing it graphically, and you start to see the complete responders. The dotted line is the RECIST criterion for partial response. Anything below that is a partial response. No one believed us. They said if you're going to give chemotherapy like that, you're going to poison the marrow, you're going to have myelotoxicity, it's going to be a disaster. So the only way to convince the oncologist is to do a prospective randomised controlled trial, and that's what we did, control nets. And recruitment, I think, is just finished, and that's now being analysed. So that'll give us the answer, and that was done entirely within Australia. If we look at myelotoxicity, over all the patients treated up to 2016 with lutetium octreotide PRRT, there were over 2,000 of them with up to a 10-year follow-up. The grade 3/4 toxicity was modest and self-limited, and it was no greater in those patients treated by combination capecitabine temozolomide therapy. And the MDS acute leukemia rate was very acceptable, 1.4%. Should we be doing dosimetry? We should, but it's impossible in routine clinical practice because the physicists demand, quite rightly, that you have to have 5 different time points. It has to be the same geometry on the same machine, necessitating 5 different visits after an administration of lutetium octreotide. And you'd have to do that after each cycle. But Hanscheid and Lassman have just published in the last 2 months a superb study where they've actually validated a single 96-hour SPECT CT and shown that the variation in these 3D maps from the integral of the median was only 5% for the tumour, for the kidneys, for the liver and for the spleen. So it is now, we are now able to do a single scan to get some realistic dosimetry. Again, combination therapy is the way to go. And we decided with everolimus, which had become standard treatment by increasing the progression-free survival only 6 months, that we could do better. So we started a dose escalation study, classical phase 1 oncologist design study. The normal dose of everolimus is 10 milligrams per day, and we started at 5. And the practical dose was 5 because once you got to the maximum tolerated dose, 7.5, you started to get having to do dose reductions. And when we did that, we had a partial response rate of 44% overall, but no progression on study. And in pancreatic neuroendocrine tumours, there was an 80% partial response rate. Now, when the oncologists did a combination study, they put everolimus with pasireotide, and they increased the overall response rate, but there's no increase in progression-free survival, which remained at 16 months. And they had quite a lot of side effects. When they combined it with BZ235, they had enormous toxicity, which led to early termination. The grade 3/4 adverse events went up to 84%. Everolimus, the objective response rate is 6%. So when we combine the same treatment with standard activity lutetium octreotide, it went up to 80% in pancreatic. So it's a dramatic difference. And of course, no one believes that. And at the moment, they're doing a prospective trial of everolimus versus lutetium octreotide in the COMPETE study. But what they're not doing is combining them. And they had a very good opportunity to do so. Now, if you look at new oncology agents approved by the FDA over the past decade, or 2003 to 13, they increased median overall survival by only 3.4 months. And there was only one approved in 2012 that provided survival gains of more than 2 months. Huge expenditure, huge clinical trial effort for 2 months increase in overall survival. They say they need new treatments. Here is an up-to-date, comprehensive review by urological oncologists published in the Journal of Clinical Oncology on new horizons in the management of castrate-resistant prostate cancer. So they had immunotherapy, androgen receptor blocker therapy, adrenal androgen synthesis blocker, chemotherapy, radioactive agent radium, that's the only one, and there was absolutely no mention of gallium-68, lutetium-177, theranostics. And when was this E published by the oncologist? In their Bible. The answer is February 2018. Worse, New England Journal of Medicine, reviewing metastatic prostate cancer. The median overall survival benefit of all existing treatments. Docetaxel is the best at 17 months increased survival. None of the others are over 4 months. There was no acknowledgement of lutetium or actinium PSMA therapy. And this was published in February this year. In Australia, we are far more enlightened, and the prospective prostate cancer management intent study done by Paul Roche and his colleagues with a multi-centre study showed that it changes the management, the intended management, in over half the patients. And if we're looking at restaging and biochemical recurrence, it's nearly, it's 2/3 of the patients. The management is changed by gallium PSMA PET-CT. This is now becoming routine with kits. So you don't need hot cells, you don't need logistics, you don't need a radiochemist. It's a benchtop kit. Takes 5 minutes, just like a technetium kit, reactions at room temperature. It's being validated. It's now 200 consecutive Australian patients with prostate cancer have had that. It's going to be used in the prospective clinical trials of PSMA 617 because it's so simple and so easy to use. We don't do dosimetry for lutetium PSMA. We probably should because it can be very instructive. And there was a seminal paper last year from Richard Baum's group where they actually did proper dosimetry over 5 time points, dose in grey. And they found that the tumour dose to the metastasis falls 64% between cycle 1 and cycle 2. And there's a concomitant rise in the kidney dose going up by 1/3. So that should inform us giving a higher initial administered activity and then in subsequent cycles less to minimise toxicity and maximise the effect. Again, we do all our treatments as outpatients, but in Europe they don't. They put them in hospital for 3 days when all of the patients have achieved the discharge exposure rates within 6 hours. So, I'd like to announce the lutetium PSMA randomised control trial of metastatic castrate-resistant prostate cancer. There's one in the pipeline of PSMA 617. What we have is uncontrolled retrospective single-centre phase 2 studies in heterogeneous populations using different protocols and evaluation endpoints, and they provide only level 3 evidence, which for an oncologist is no evidence at all. We assert that the objective response rate's about half, measured by PSA falls of greater than 50% or by gallium-68 PSMA scans. We assert that the median overall survival is 27 months, and we assert that the quality of life is improved. But we have not shown that. How do we do that? Well, you can wait for the randomised control trial. So even if it starts at the end of this year, it'll be 5 years before we have the evidence, especially of overall survival. Or we can do something as nuclear physicians. And Warmth is coordinating the NIGHTCAP study, which is National Investigators Global Harmonisation of Theranostics of Cancer of the Prostate. It's a coordinated, prospective, international, standardised protocol, and it's an audit. It's an audit because all of the people doing these studies now don't have to go to their ethics committee. They don't have to go to the regulatory authority. They're authorised now. So whatever ways in which they're doing those studies, we can piggyback those. So we're looking at the theranostics in a patient population I've conservatively estimated at 2,000. We'll probably have 4,000 recruited in 1 to 2 years. And we're looking at primary endpoints, the primary endpoints which matter to the patient, which is overall survival and quality of life. Secondary endpoints may also be looked at, and toxicity is important to look at, but they're of secondary importance. And the inaugural investigators meeting for the NIGHTCAP study is being held here on Monday, and 30 centres have expressed their interest in participating. So this will be the first non-pharma Warmth coordinated study, and it's being supported also by the World Federation of Nuclear Medicine and Biology. So the future is in our hands, and that surely will convince not only oncologists, but it will convince patients, because patients are well aware of what we're doing, and our referrals are often coming from patients telling their oncologists that they want theranostic therapy, they don't want to be poisoned by chemotherapy. Thank you very much.
Thank you, Professor Turner, for your comprehensive and, as always, thought-provoking talk. And thank you again also for your pioneering contribution to nuclear medicine in Australia and, in fact, the world, particularly in the area of theranostics. I'd like to open up for any questions that you might have with Professor Turner.
Can I start?
Yes, sure.
In the initial study, you said you were treating to 0.75 Gray. That was the target. What was the range of administered activities in the patients to get to 0.75 Gray? Do you recall?
Yes, it was 1.3 gigabecquerels to 6 gigabecquerels.
So quite a wide range.
Oh, huge.
And
yes.
You need dosimetry beforehand to be able to determine that.
Yes.
And I was also going to say it is fantastic to see Australia leading the world in so many of these areas, and There is the randomised clinical trial of lutetium PSMA, randomised with chemotherapy through ANZUP and ARTNET, which Michael Hoffman is running too, which is another area that we've been able to work together in Australia, which is fantastic that we are able to do it. And a lot of the work that Professor Turner has done builds on those concepts as well. So, is there any other questions?
If not, could Professor Munoz Ferrada please join us back on the podium and we'll present you with the plaques.
So it's our honour to present the plaques for both of the lectures performed today, the Lowenthal lecture and the Pioneer lecture.
Congratulations.
So, you go first, Ross.
You got the right one?
Both of you together. I think you join me in saying that these two individuals really exemplify the purpose of these awards, and that they've been two terrific presentations summarising careers in this field for which they've been leaders and for which we thank them and are very grateful. Thank you very much.